you kind of have to put the onus or the burden on the patient saying, you've spent all this money and all this time. The one thing you can do to keep your teeth, your implants last longer is really take good care of them.
Welcome back to the Tooth or Their podcast, Peeps, with your peep Irene, joined with a very special local friend, Dr. Effie Habsha. How are you today?
I'm great, Irene. How are you?
I'm good. We live in the same city, except we never see each other other than one or two events per year. I feel like we're
exactly.
just two ships passing in the night in most days.
That's very true.
Yeah, I got to know you a little bit better over the last little while, but I want to know a little bit more about you behind the scenes. Who is the woman behind the woman? Can you take us back? Let's
the woman
take us back
the
to
woman.
birth. Yeah,
oh my God.
Where were you born? Where did you go to school?
I don't want to bore you guys too much.
You have to tell us the year.
No, I don't want to bore you too much. I think
it's really great.
Well, I was born in Tel Aviv and emigrated here when I was really little. So Toronto is home for me. And all my schooling was done in the city in Toronto, including dental school and undergrad, grad school. So I was very focused and, just stayed locally. But I've more than made up for it later on in my career with all the traveling that I'm doing. But I had a really, great upbringing, good schools, good friends, good community. And then that kind of carried through into the university years and dental school and beyond. So Toronto is where I call home.
Cool. Any hobbies?
Hobbies?
Yeah.
Travel.
Okay.
Working out, although I'll have to admit, I'm not doing that much of it these days because work is taking up a little bit more of my time than I would like it to take these days. So right now I would say, just hanging out with my kids whenever I can, traveling whenever I can, and then just trying to stay above water because things have been very busy. And I think the feeling as well.
Oh yeah, absolutely.
Yeah.
And as soon as you feel like you've caught up a little, 5 other things get dumped on your plate.
Yeah, I think you just have to get used to the concept of not ever really feeling caught up. That's what I talked to a few people that are in the same boat that just, you just have to embrace that to go, it's okay. There'll always be something more to do because I'm never caught up.
Embrace the chaos. Yeah. Do you have any like rituals, any like every morning I wake up and I have to do this? Any tips for those of us that haven't quite figured out how to manage stress?
One thing you'll know about me the more you get to know me is I'm pretty brutally honest. And I could say that I wake up and I go on my Peloton and I ease into my day, which I have the intention of doing that every day. But that's not quite how it happens. So I tend to be a bit of a night owl. So I stay later than I should, probably trying to keep up with my kids who stay up later and later the older they get. And so really I try to maximize the amount of sleep that I get. So waking up kind of just in time to always be on time, but just like not a lot of lead time, not one of those, wake up early at 5 a.m. If I wake up, about a half hour to get ready, get to work. And then I think
that's just efficiency. That's like a level of efficiency. Yeah. You're efficient in all of the things that you do in order to maximize the time that you have available to do it.
That is a euphemism for just keeping things very tight. I like to have kind of things condensed in my day. So sleep, maximize my sleep, and then but my days off, my one morning off and weekends, that's when I kind of work out and do kind of the self-care stuff, which is not enough. Good. But yeah.
Tell me about your clinical practice. So you graduated from U of T, Bachelor of Science, Prostho, and then what? So what did you always know you wanted to be a dentist or be in dentistry?
Yeah,
how did you figure that out?
I went to high school where, pretty much it churned out doctors, dentists, lawyers, accountants, and which is great because I had that focus in mind. So it was kind of cool to be studious in my high school, and which incidentally is the same school that my kids go to. And so yeah, I kind of knew I wanted to be in the health sciences. And when I sort of was an undergrad, I actually, had a bit of the imposter syndrome that's so popular now. I didn't know what it was called back then, but thinking, well, I don't know if I can make it. And so my first year, I kind of split between health science and business. And so I took economics and poli-sci, which were my two worst courses, and I excelled in sciences. So then I knew my path was to go down the medical science, the health and medicine, and then just dentistry just really appealed to me because it was, a bit of a business, art, science. It sounds a bit cliche, but my intention at the time was to get in, do my 4 years, and be done. Because unlike medicine, dentistry, you could just do your 4 years and get to work. But that isn't quite how it happened because, life happens when you're busy making other plans. So get into dental school, chance encounter with one of my mentors, Professor George Czar, when I cornered him at the elevator and asked him if he had a job for me as a summer student. That was after my first year. And that really introduced me to the love of prosthodontics because, I had no intention of I didn't even know what a prosthodontist was, like a lot of people. And so after my first year in dental school, I worked as a summer student in the Prost department. And then I was just hooked. I knew I just had to pursue that specialty. And kind of everything sort of accidentally falls into place. And that's sort of how my professional career has really has kind of become what it is. It was, a coincidental accident, but a positive. I mean, I say that tongue in cheek because I think, there has to be intention behind everything.
Luck and hard work look a lot like the same thing, right?
Yeah. So it's been a very organic growth. I've been very lucky to have a lot of really great mentors who have educated me and then taken me under their wing, in my private practice as well. So I've been at the same practice since I graduated, it was one of my instructors in grad school that I joined his practice. And then we've just sort of expanded immensely from there. And then all the other paths that I've taken professionally have kind of organically happened for me. And I feel very fortunate to have been offered those opportunities, but then to be able to kind of run with them, which has been really great.
Yeah. So what does that look like applying to the Prost program as a dental student? So you didn't practice, you went straight from dental school to Prost?
I did a 1-year GPR. So I did a residency at Mount Sinai. And I think that's always a good way to go. Like I strongly recommend even for any dental student graduating to consider doing a residency because I think it just makes you a better dentist, just sort of seeing the way things run for medically compromised patients, et cetera. And you get that extra year of confidence in your skills. So I did my residency at Mount Sinai. And then, again, I was very lucky because I knew exactly what I wanted. So I just zeroed in on that and made sure. I mean, I had 3 years to prepare as an undergrad student. So, I did some research and had kind of beefed up my resume to be a competitive applicant. And then I got lucky and was admitted after 1 year of residency, and then did my prosthodontics degree and Master of Science as well. All the while kind of juggling a life. Back then I got married after or right before grad school and popped out my first kid, like just when I was done my master's. So it's those, women that are watching or listening. Yeah. You can do it. You just need to have
what you gotta do. Yeah. Figure it out as you go.
There's no one set path. It's just anything, whatever path kind of speaks to you seems to have worked for me, to be honest.
Yeah. So if you were to describe to a listener who perhaps doesn't refer to a prosthodontist, or that's just not the type of work that their practice does. I mean, we've got people from all over the world that listen. How would you describe what kind of a day in the life of you would look like, or a prosthodontist in your practice? Let's talk about perhaps some of the procedures that you do, and then lean into afterwards, when to refer to a prosthodontist versus when to refer to a periodontist or oral surgeon. Maybe we start with the the day in the life of Effie first, after
day
she's
in the
used her
life.
Peloton in the morning. After
the
the
intention
Peloton
to use the
and the
Peloton,
all black.
So exactly.
The
That's
blow
a
drying
cup
of
of
the
tea and
hair
that's
and
it.
the freshly
No.
pressed orange juice.
I wish. The day of a prosthodontist in my life is pretty hectic. Thankfully, I have a very good team. I know you always talk about your team, and that's the only way you can make it happen. And this is, years of working with really great people because they point me in the right direction. So our practice, it's a multidisciplinary practice. We have 10 specialists, including surgeons, periodontists, endodontists. And so we're kind of a hub, like people can refer to us if they want, a specific procedure or just one-stop shop for their patient to be seen from diagnosis all the way to delivery of treatment, if it includes surgical or any sort of multidisciplinary care. So in a given day, I'll do any number of procedures from implant surgery. So I'm placing my own implants, conventional crown and bridge prosthodontics, implant, single units all the way to full arches, fixed, removable, really anything cosmetic. Porcelain veneers is another big passion of mine, so I do a lot of that. And so it just keeps it very interesting. I think you're kind of like a super dentist, but no, mind you, a general dentist I think is a super dentist because they've got to know everything from endo to surgery. I focus my skills on surgery and prosthodontics, which I really enjoy. And so the day is often very busy. We often get, our regular referrals of dentists who feel that perhaps a patient's care is too extensive for what they need to do. But we also get problem cases when people run into problems. So any given week, we have multiple referrals for fractured implant components, a lot of implant stuff, because the more people that are placing them from different parts of the world, you get all sorts of funny things that I'm sure you see in your practice as well.
Oh, yeah.
So we've got the reputation kind of, any problem sort of situation you send to us or to a prosthodontist. I think prosthodontists tend to be the ones to bail people out a little bit. So that's been our experience. So
absolutely. And some, I don't know about you, but perhaps those are some of the most kind of not fun cases, because you don't want to create fun out of someone's disaster, but they really get you thinking, especially when someone has gone, let's say, overseas and had almost every single tooth in their mouth prepped, and the preps perhaps weren't the greatest, and now you're taking off this either fractured or disastrous work, and you're trying to think of the longevity of the next restoration that goes in. I mean, the reality is there's a lot to consider. So that takes a lot of planning. What are some of your favorite tools that you use, systems, softwares that you'd say, without this, I couldn't do the amazing work that I do?
I think, to be honest, this is going to be a very broad answer, but digital technology. And I'll tell you, I mean, I just right now, so I was running a little bit late. I just delivered provisionals on a patient, and really having the digital tools from the outset, from your smile design, has been a game changer. So just for example, we'll keep it simple to, let's say, 6 anterior units. This particular patient, I prepped 10 teeth. And she had a whole bunch of things wrong with her smile. Her smile line was inverted, her teeth were short, so on and so forth. So a typical traditional way or conventional way of addressing that would be to do a diagnostic wax up and then a mock up and taking it from there. And if your laboratory technician doesn't have the patient, in front of them, or the virtual patient, it becomes a little bit somewhat arbitrary onto how to set the teeth, how to, get perfect anatomic contours in relation to the patient's face and lips, etc. So by having digital technology, just even at the very beginning, or especially at the beginning for your smile design, it allows us to create your provisionals or the mock-ups kind of perfectly suited to the patient's face. So that really eliminates a lot of chair time and kind of going back and forth and fine tuning something. And then if you carry that concept throughout, having the digital tools, intraoral scanners, and, CBCT guided surgery, it really improves our predictability. So my dentistry is, I think, so much more efficient, and I think a lot more aesthetic and better quality these days because we have all these tools at our disposal. And it's pretty remarkable, like the thought of kind of going back and doing things conventionally or an analog process really doesn't bode well. But you need to learn how to walk before you can run. So you still have to have the education in the fundamentals and then build on that to do the cool stuff with digital technology. That's been a game changer for sure.
I remember I worked in a cosmetic focused practice in Yorkville when I graduated dental hygiene school, 3 years out. And I remember he would take Polaroids of patients' smiles and would mark it up by hand.
Yeah.
And then we went from Polaroids to physical photos, and the photos would then be printed and marked up by hand. And I thought that was just such a cool thing 17 years ago, that was how we were creating and designing smiles, and then putting the Polaroid inside the little box with the impressions to the lab. And now I see what we can do chairside now, and it's just, I don't know, it's the millennial in me knowing how far we've come and just imagining how far we still have to go. Have you incorporated any 3D printing into your practice?
Yeah, so definitely. So we're 3D
printing provisionals?
Not yet. I'm still milling them, but I just had a meeting with Sprint Ray. They've got some really great materials, printable materials for provisional fixed partial dentures. So printing all our guides, night guards, any, those sorts of appliances. Provisionals, haven't gotten my hand on that yet, but, that's definitely, printing ceramics is a thing. Zirconias, which
that's
I'm not doing
crazy.
yet, but all of that stuff is just coming down the pipe. Yeah. And what we're able to do because of new materials that we weren't able to do before. So I think it's a very exciting time to be practicing dentistry. I really enjoy it.
I do too. I graduated from restorative a little while ago. So, I don't do quite the volume. And I say that with such a very humbling feeling that you do quite the volume. But I don't do anything close to what you do. And I just find it so fascinating to see the transformation in someone's smile and in their life. Even just something as simple as the pre-op to post-op photo. It really transforms people's lives. Are there any cases that you can think of off the top of your head where you're like, that was a formative case for you as a clinician, that it really was impactful for you?
And they don't even have to be the huge cases. Sometimes with the very minimal modifications, you could make a tremendous impact. Obviously the first ones that come to mind are the full arch implant, immediate extraction, immediate placement, and immediate load. Those are just phenomenal. I've done quite a few of those very predictably, and being the surgeon as well as the prosthodontist is really, really cool. But sometimes it's even the little things, and those are super rewarding. So one that just comes to mind now is a family friend. I've known her since she was, I've known her parents forever. So since she was a baby. So fast forward 25 years or so, and she's now graduated dental school and getting married. And she always had a bit of a gummy smile, and but obviously being a dentist, she didn't want a mouthful of veneer. So we kind of went back and forth. And with a combination of, she had a gummy smile, short looking teeth, a little bit of incisal wear, with a combination of just very minimal dentistry. We did some, gingival contouring with our periodontist, Dr. Schur. He did some crown lengthening. So that's not that minimal, but some crown lengthening, some whitening, a little bit of Botox to bring the lip down a little bit so she wasn't revealing much of her gummy smile, and then just direct composite restorations and bonding very specifically using a smile design to guide that made all the difference. And then I was at her wedding and she was like, I love my teeth. And that was just with direct composite. So, when you talk about your experience being a restorative hygienist, hats off to you. And Retha McDoom is our restorative hygienist here. So I give her,
she's great.
I give her my, restorative cases, and she does them so beautifully. And I'm sure you do that so beautifully as well, because you're focused, you've got the time, and you sit and then create these beautiful smiles. So I think it's not only the large, ear to ear porcelain, which are so gratifying when you're recovering vertical and the patient just looks so much younger because their face isn't collapsed anymore. but also the little things that you can do that make a huge impact that I find is super rewarding. So
yeah, totally. Speaking of full arch cases, you talked about some of those huge impactful cases. What does a post-op look like? So you've immediate extractions, immediate placement, immediate loading. Then what? What is the next 24, 48, 2 weeks
believe it
look
or
like for
not,
that human?
I'll tell you.
Are they drinking through a straw? Like what's
So if I go back to kind of the whole digital workflow, back in the day, I mean, I didn't do those surgeries, but I should say back in the day, it's obviously the conventional freehand way of doing things. For example, an immediate load or an immediate extraction implant placement. If you do it conventionally and elevate a flap and extract the teeth and then freehand putting implants in, and the converting or fabricating an immediate load prosthesis, that takes a lot of skill and a lot of time. And the more surgical time it takes, the more elevation of tissues you have, the more postoperative discomfort you have. So really what turned me on to guided implant surgery was back in 2005 or 6, my colleagues and I went down to Portugal to see Paulo Malo, who is, the all-on-4 guy. And we saw him do all these guided implant surgeries. Back then, it was very, very novel, where you can go in and in a guided, flapless manner, place, 4 to 6 or more implants. And based on that, and have a prosthesis on hand to immediately load. And so when you can offer that service to a patient, so, fast forward all these years, and I'm now doing this as well, not only are we able to predictably place the implants, but we're also able to mill or print even our provisionals in advance that we're able to deliver right away. And that's all to say that the postoperative look for the patients, because there's so much planning in advance, our occlusion is often perfect. Our emergence is often really well adapted. And because it's done guided and flapless, I don't like to remove bone if I don't have to. The postoperative situation for the patient is really remarkable. So I can tell you from the patients that I've had, that I've treated very recently, they are just shocked and amazed at how easy their recovery is. And we, of course, recommend a very soft to liquid diet for, depending on the stability of the implants, but not to get too technical. But it's amazing what we're able to accomplish.
The post-op is always the most interesting thing for us that don't see these patients. We see them come back, and perhaps we'll talk a little bit about maintenance. I know you did a Seattle Study Club tip that I found very helpful back in 2022. And I think that that's something that most hygienists and perhaps even, the referring office, we're disconnected from that procedural part. We're disconnected from the quality and the quantity and the integrity of the implants and what challenges you may have faced while you were doing that procedure in order for us to then know what we do for the rest of this human's life if they never come back to see you, which I know that you have a great maintenance protocol. But some of the feedback I've received from other specialists I've referred to is that they wish that they would see those patients back more frequently in order to keep an eye on things. So what would you say some of the most important things are for us as clinicians? A single tooth implant, perhaps, or a couple of teeth. What should we be doing, and what should we be looking for?
Yeah, I think that's a great question, because I'll have to admit, again, full transparency. When I started practice, we didn't really think much about, plaque around implants, obviously oral hygiene to an extent, but not to the extent that we know now is so important to maintain. So I remember, someone kind of, I don't remember who, but saying, well, plaque around implants not a big deal because implants don't get cavities.
And they don't get calculus,
or cavities, because you can't get caries around an implant. And so that was kind of like, before we kind of understood what was going on a biologic level with peri-implant mucositis and then peri-implantitis, it was kind of a little bit of the Wild West where we, I personally didn't give that much kind kind of importance to meticulous oral hygiene, specifically around implants. And then fast forward a bunch of years, and then you go, oh, well, hang on, there is a connection here. And more studies and research obviously show that, what's in the patient's control, in our control after, everything is said and done, is oral hygiene and maintenance. And that's where, a good team of following up with a combination of our hygienist and our dentist. Of course, the patient has to be very much engaged in the process of meticulous oral hygiene. And, I recommend a specific, toothbrush and dentifrice that is specific to, having bactericidal qualities, like a stannous fluoride toothpaste.
Stannous fluoride. Yeah.
Stannous fluoride, which again, I mean, if you ask a lot of dentists, I don't remember the last time someone spoke to me about fluoride, since dental school. And then I'm like, I was introduced by my Oral-B rep back then, Robin Shields from Crescent Oral-B, and kind of read the literature and went, oh, there's a difference between stannous and sodium fluoride. Okay, I kind of forgot that, or maybe it wasn't even around when and so just now, my approach with patients is very different, that, I am part of that conversation. I think it's important for the dentist to be, part of that conversation. And then, of course, the hygienist, I mean, you guys do such a great job at that, but it really has to come from both clinicians. And you kind of have to put the onus or the burden on the patient, saying, you've spent all this money and all this time. The one thing you can do to keep your teeth, your implants last longer, is really take good care of them. So water flossers, any oral hygiene aids to do that. And that's really been
avoiding
a mindset.
Avoiding things that'll fray. I mean, so when I went to dental hygiene school, same thing. We learned oral hygiene instruction in like second semester or first semester. We had to create a little flip book, and that flip book went into clinic with us, and we went through modified baths, Stillman's, and the toothbrush technique, and a variety of different things. And it seemed that floss was like at the top of the list, that everyone had to do interdental care with floss. But the more and more research came out around implants and peri-implantitis and its precursor to mucositis, and that it's actually not advisable to use floss, especially when there are threads that are exposed, because using an endoscope, you can see small itty bitty little particles of either frayed floss or pieces of plastic, pieces of wood from toothpicks. So physical irrigation using water and air is the most efficient at removing biofilm around these structures. And yes, you can get calculus if there are threads exposed and margins exposed, just like any other tooth. But I think the biggest thing that we as clinicians, as hygienists, should be doing is evaluating the tissue, because usually the body will show signs of inflammation far before the radiographs do. Looking at the color, the consistency, the contour, and physically touching around the implant tissue to see what fluid is coming out of that quote unquote sulcus, or whatever we were calling it. Doesn't have a sulcus, I guess. But that's really, valuable. And the question of the hour that everyone has is to probe or not to probe. Should we be probing implants? Now, I've asked a variety of people, including my friend Mia Geisinger, upcoming president of the AAP. She kind of rolled her eyes a little bit, and she said, well, what are you looking for? And that's a great question. If you weren't the person to place that implant, what is the baseline? So should we be in there as clinicians who weren't the original ones placing the implant? Should we be in there poking around? I don't know. I feel like I'm not qualified enough to mess with the structure that I didn't place. What do you think?
I think it's a very good question, and I'm going to go by what I heard one of my colleagues, Parvane Bairami, speak about. That was one of the questions that was presented at our continuing education course that we do. And she says that it's curious that on an odontogram, you don't have the option of placing probing tips around implants, or at least she does recommend probing, and she showed the anatomy of sort of a tooth and the periodontal fibers and everything that kind of look around a tooth versus an implant. And her recommendation was to probe gently around the implant. And the question of plastic versus metal, I think it was specific indication. So I'm not an expert matter on that, but my understanding is, gentle assessment of the site. If that means with a periodontal probe, then I think her answer was yes, you should probe around there. So
This is the question that everyone gets and asks. And I think one thing that I learned later in my career is the anatomy of an implant based on who it's made by, whether it's fixture level, whether it's bone level, which now I know many are mostly bone level. Those aren't things that we learned in dental hygiene school. What an abutment could look like, and if there are a variety of different angles and things. I mean, those are kind of advanced level pieces that hygienists don't learn until their CE days. So I always wonder, what did Irene 1.0 do? Yeah, well, it just wasn't part of the conversation. It wasn't. If it's not in your scope,
there's so much to learn.
You learn very little about it. So I wonder, what did Irene 1.0 back in 2007, 8, 9, and 10, before I worked in perio, actually know about what I was doing? So if that's kind of a curious question.
You seem to have figured it out.
I figured it out over time, right? Well, I'm going to end this part 1 with you, and I want to get into a part 2 where we talk about women in dentistry, which is coming up pretty soon.
Perfect.
So everyone tune into part 2 with Dr. Effie Habsha, talking about her initiatives on connecting us women in dentistry here in Toronto and now internationally and globally. So stay tuned. Thanks for being here, Effie.
Thank you very much.